Thanks for that introduction, John. And I'm absolutely delighted to be here today to talk about a cause close to my heart. And my thanks to Mairead and the HRB for this invitation. And I think my presentation follows on really nicely from the two previous presenters, Esther and Mark, because I could see huge common ground actually in what we're talking about. And a lot of what Esther shared with us is very helpful for the journey we're on. And Mark, of course, referred to the digital landscape, and we are on that journey here due to the European Health Data Space in particular. That legislation will require us to have an electronic health record, and there has been really good discussion and movement on it under the leadership of Damien McCallion. But I want to talk anyway about enhancing patient outcomes through academic health science systems and why we really need to pay attention to the development of such a system. So you can see that the overview of my talk is I want to talk first about the context for health research in Ireland. The world-class impactful research. It's not that we're not doing fantastic research, we are, and I'm going to give you some examples because I get terribly excited about the research that's going on in this country, and I think we need to celebrate it. Our relative performance with clinical trials, though, represents a cautionary tale. And our research governance and how that's been developing, and to share with you how that's been developing, but how we need to ensure that it develops and is implemented in the right way so that we can combine the academic and the health service strengths. And finally, I want to focus on what is an academic health system and why we should have it, and also the emergence of academic partnerships and the key role that the Chief Academic Officer plays in that bridging between the two sectors. So I think we're lucky that our National Service Plan calls out the need to use the best available research and evidence to inform not only patient care, but health service management strategy development and reform. So that shows a great acknowledgement by our Chief Executive, Bernard Gloucester, on the importance of health research in all aspects of what we do. Also, in the recently published Programme for Government, the Programme for Government calls out that they will ensure rapid access to new medicines and treatments, increase the number of clinical trials, better support, provide better supports for staff to focus on clinical trial activities, and encourage academic and research contribution to the solution of societal challenges, including healthcare. So, hopefully we're pushing an open door, the context is there, and we should acknowledge those among us who are in the Department of Health and in the HSE in leadership positions, because these themes did not find their own way into the Programme for Government. They had to be very carefully shepherded in. So it's really good to see. So in terms of the landscape here, look, we have lots of different sources for funding for health research. Yes, we could do with more funding, and we all need to advocate particularly for more funding for the Health Research Board. That needs to have greater investment. So we have all of these sources. We've Irish public funding, we've international and EU funding, and indeed, I think we punch above our weight in terms of EU funding. There's a lot of great leadership in this country there. Industry in the private sector, and philanthropy and charities. Lots of good sources of funding for us. And indeed, this funding has been put to great use. And I want to give you some examples here. The first one is the development in UCC under the leadership of our Professor of Gastroenterology, Marietta Ucci. I was lucky to recruit Marietta to UCC. She came to Cork really based on the work of the APC Microbiome Ireland, an SFI-funded research centre. So it just shows how having strong research centres actually can help us to recruit really good staff. So Marietta has managed to acquire the most modern, technologically advanced imaging equipment for our gastroenterology units in Cork. And this imaging is really powerful in the hands of experts, but you do need experts to read the images because the images are prone to subjectivity, inter- and inter-examiner variability, and as I say, it's great for experts. However, the advent of artificial intelligence means that experts can now read the images and use machine learning to train the computers with artificial intelligence to do better diagnosis. So we get a better endoscopic assessment, we get standardized measurement, we get objective measurement, and we get rapid diagnosis, leading to accurate predictions, better outcomes for patients, and better responses to therapy. So it's tremendous work, and it's really great to see her leading the way internationally in this. Another one close to my heart, again in Cork, is AI providing a window to the newborn babies, so the newborn brain. So the problem is that brain injury affects 3 to 5 out of 1,000 newborns, but it's often presenting as silent seizures, which traditionally it's been up to the consultant to spot the signs of this. But they trained machines to learn when, based on thousands of baby brainwave monitors, to spot which babies would develop seizures. So through doing that, now they can accurately predict, more accurately predict which babies are at risk. And a European trial has shown a 50% increase in detection. Now this is a massive move forward because it'll avoid the brain injury for those babies successfully detected. So I think it's fantastic. We have 2 spin-outs, Surgenix and Neurobel, and they are advancing this all the time. Not only have they developed it, they're miniaturizing it now and making it more affordable so that every newborn baby incubator can have this to predict which babies are at risk. Superb work. And you heard about the great work going on cancer trials in Ireland, and under the leadership of Professor Roisin Connolly, we've established a regional clinical trials partnership with the support of the HRB. And this is allowing us to have economy of scale in terms of our trials. It allows us to attract more trials and do more and better trials. So really tremendous to see that going on. And finally from Cork, we have the stop-start criteria developed over years by Professor Denis Amani with funding from the EU, from the Health Research Board, from the Swiss government. And these are explicit system-based criteria designed to optimize medication for older people. As you can imagine, as people get older, they take more and more medications. You get a lot of drug interactions, a lot of unexpected and unwanted side effects. And so this system allows us to reduce that dramatically, and it's been adopted very widely internationally. And as Irish citizens, we should be very proud of this kind of work that's impacting practice all over the world. And interesting to see even the Dutch government have adopted it. So it was interesting to hear Esther mention about the percentages of inappropriate prescribing. So this hits that very nicely. It's not all about Cork, of course. There's great work going on in other places as well. And my colleagues would kill me if I didn't mention them. And sure, the University of Limerick has done fantastic work. We heard about their work in cancer, which is really impressive on the digital end. They've also done some work on comprehensive screening of older adults turning up in the emergency department. And they found that through comprehensive, opportunistic screening and comprehensive assessment, they are providing much better outcomes for older adults in that system. And great credit to Aoife Leahy, who did her PhD on this project. Finally, in St. James and Trinity, they've been doing amazing work on CAR T cells, and CAR T cell treatment is incredibly powerful for treatment of cancers. And in particular, you see much better outcomes for adolescents and young adults when they are on this treatment. And you can't bring that treatment, though, cold into a system. A research active system is much more amenable to introducing such new therapies. And indeed, they've been running CAR T cell clinical trials in St. James, and other trials are likely to follow. And my thanks to Martina Hennessy for her slide there. So, I think we're stuck. So all great news, lots of great things happening, but we still have a lot of problems. We still have the newspapers daily are full of issues in the health service. Many of these issues, though, could be addressed with better integration of the academic and health side. If we had integration of our spirit of inquiry in a learning health system, a system where care informs research and research informs care, many of these issues could be the subject of a learning health system and addressed through better integration with research. So we must ask ourselves, and I ask all of you to reflect, are we reaching our potential? Can you imagine a future where research seamlessly translates into better lives for our citizens, and how we might create this reality? Although we feel we're doing really well on the internationally impactful research we're doing, the number of clinical trials we run tells a different story. And you can see here that looking at 3 countries, Ireland, Denmark, aforementioned, as doing really well on the cancer outcomes, and Finland. Ireland has a stronger economy, actually, than the other 2 countries. However, our population sizes are similar, but our performance in terms of setting up clinical trials is much poorer. Now, another fact you can see here is that the setting up of clinical trials in Europe altogether is declining, with phase 3 studies being set up outside of Europe in other countries. But the story still remains that we run fewer trials in this country than in other European countries. So we do need to address that. We need to see why it is, and we need to try and up our game. And indeed, I know my colleagues are working really hard to address that differential. And some of the issue is perhaps the regulatory context for health research. It has become more and more difficult to conduct research in this country, and other countries face similar problems, but little wonder that our clinicians find it difficult on their own to set up research. So I think clinicians and other researchers need support to navigate this system and to make research-infused clinical practice an option for themselves. So today I'm focused primarily on research, though, and the academic health science system, which is an approach to addressing this support and infusing the research within the health system. The academic health science system, which I'm going to talk about, is not only good for research, but it's good for education, training, innovation, and simulation-based training as well. So academic health science systems, it's like a triple helix powering health research. The triple helix is the weaving together of health service, higher education institutions, and industry. It's a learning health system. And you can see here that I've illustrated it as a pyramid with the health system in it, the university, and the life sciences industry. And by bringing the 3 of them together seamlessly in a collaborative approach, working together in a collaborative way, we can have a multiple win, a win-win-win-win-win. It's a win for the collaboration, gives you the possibility of a learning health system, where I said research informs care and care informs research. It accelerates innovation, it enhances patient care, it offers better outcomes for patients, which I must say is the principal driver. It enriches education, providing an environment with a research-infused environment with cutting-edge training for students. It provides career development for staff, and it enhances recruitment and retention of staff. And it also provides for economic growth through research-driven healthcare advancements. What's not to like? However, the current situation is more like this. It's more like the 2 systems working in parallel, with touch points on joint appointments, clinical research, education, training, and simulation, as well as innovation. Industry can navigate this system, but it takes a lot of effort. So it's not straightforward. And we do have a lot of benefits of the current way of working. All of these areas benefit. You see recruitment and retention, job satisfaction, outcomes of care. But are we maximizing on the potential? I would suggest that we're not. And through the better integration of our sectors in an academic health sciences model, we can develop trust and shared practices, increasing opportunities for joint appointments, etc., and supporting each other to deliver better patient outcomes. So everything benefits from this collaborative approach. And we provide a single truth for industry, which can navigate the system seamlessly and allow for that triple helix really to kick into action. However, this is not going to happen on its own. It requires leadership. And I was interested to hear Esther saying that very thing and question who is leading it, and the fact that we should all lead it. But it does need it needs to be somebody's job to get out of bed in the morning and make this happen. So before continuing, I want to come back. I said the compelling reason for all of this is patient outcomes, and I want to remind ourselves of that, and I'll keep reminding you of it through this presentation. The graph that really speaks to me, and I've used this graph many times, and my thanks to Professor Jean Dempsey in Cork University Maternity Hospital for this. This is the survival by week of gestation in Cork University Maternity Hospital from 2003 to 2020. If you look here, you see the percentage survival of premature babies. And you can see that back in between 2003 and 2007, prior to the opening of the new maternity hospital, if your baby was born at 23 weeks, the chances of it surviving were 14%. Very slim chances. Got better at 24 weeks and better again at 25 weeks. Following the introduction of the move to the new maternity hospital in Cork, these figures increased substantially. The 23-week-old baby had a 33%, 1 in 3 chance of survival, which is absolutely fantastic, and survival rates improved for the older groups as well. Following the establishment of the research centre, the infant research centre within the maternity hospital, and it's closely interwoven with the clinicians, and the researchers work hand in hand, these figures improved dramatically. And you can see now that our 23-week-old baby had a 55% survival rate, more than a 1 in 2. So really fantastic to see, and you can imagine the number of lives this has impacted. And again, as that has grown and grown, the survival rates for the 24-week and 25-week gestation babies has improved even further. So I think this, for me, illustrates really the power of the academic health sciences partnership. If that's not enough for you, take another example in a paper by Ozdemir. Ozdemir looked at the mortality outcomes for acute admissions in UK hospital trusts and found that controlling for other variables, those trusts that had greater income, research income for research and that were more research active had substantially lower patient mortality rates following acute admissions than other hospitals. So again, good evidence that this partnership, this academic health service partnership, has powerful benefits for patients. I believe we're pushing an open door here in trying to establish this model, as the Sláintecare implementation plan published in 2023 acknowledges the power of this approach. You can see where it's talking about the move to the regional approach and the desire to build on the benefits of academic health science systems as we make that transition. And indeed, fantastic work has been done nationally on moving to this model. On the HSE side, you can see that back in 2014, with the publication of the hospital groups with academic partners, it was decided to establish the role of chief academic officers. So that was the first move. Then you had the development of research governance framework. Now that only happened because the HSE appointed an assistant national director for research, Anna Terres, whose job it was to lead the development of a research governance framework. And Anna's work has been hugely beneficial to the establishment of a research infrastructure in the HSE hospitals. I must say many of the voluntary hospitals already had a research infrastructure, but certainly in the case of CUH, which would be the largest HSE hospital in the state, we did not have a research infrastructure. As well as that, Anna has been working on the reform of the Research Ethics Committees nationally and the National Electronic Research Management System. And so that has resulted in a system which facilitates research. Now, what's really important, it's really important that as the HSE was developing all of all of these documents and infrastructures, that the universities took note of what was happening and made sure that university systems and that clinical research, which was largely governed through the university system previously, aligned with the HSE systems, and that the two infrastructures could collaborate with each other. Because you remember that perplexed clinician with all of that legislative framework and the barriers perhaps to clinical research. We need to remove those barriers, so we need the universities and the National Health Research System working hand in hand. So the Chief Academic Officer role, which is a bridging role between the universities and the HSE, is incredibly important to navigate this new development in our system. So we've been working on the design and implementation support for that national framework and working to align with the new research ethics committees and align with the National Electronic Research Management System to ensure that our research can be truly collaborative. And to this end, again, it's going to be a win-win-win-win-win for everybody concerned, for patients, staff, researchers, for innovation and enterprise. And the electronic health record, as it's introduced within this kind of system, will be prepared for research. So it will factor in the need to access data for health research, which is incredibly important to get that right from the outset. So here you see Sláintecare is supportive, the work of Anna Terry's and her team, and you can see the documents there that she's produced. The National Oversight Group for Expansion of Clinical Trials is supportive, the National Service Plan, the draft programme for government. We have the wind behind us. So I want to have a look now at what's been happening in the university side in terms of all of these developments. It goes back to the establishment of the Chief Academic Officer role, and when I was appointed as head of the College of Medicine and Health in UCC back in 2017, my role also involved being Chief Academic Officer for the region. So Jerry O'Dwyer, the then CEO of the region, the hospital group, was on my interview board. So that allowed, that was also mirrored in the other 6 regions in the country, and we ended up with 7 Chief Academic Officers, the 6 hospital groups plus Children's Health Ireland. At the start of the pandemic, that group started meeting weekly because we had a lot of work to do to make sure that students could maintain placements and that the universities could respond to the needs of the health service right through the pandemic. And it was very effective. We met weekly. We contributed to the consultant hospital the non-consultant hospital doctors education and training task force. We took on the clinical educator pilot and worked with the NDTP on a clinical educator pilot. We worked on a simulation strategy and getting funding for the development of a strategy for simulation-based training and piloting that. And now I'm delighted to say we have in place Dara Byrne as the National Director of Simulation-Based Training with a strategy. We worked on the clinical placements. We input into the new contracts, new consultant contracts, to make sure they had enough time for academic endeavour in their contracts. We worked on the development of COVID biobanking, and we fed into the research governance framework. So a lot went on, and it was all about ensuring that we had a system that rewarded academic endeavour and really bridged between the academic side and the service side to ensure high quality patient care and to enhance recruitment and retention of staff. So these are all the reports and all of the areas that the group have contributed to, and the group hasn't done anything on its own, but it has provided an impetus for other groups to do this kind of work. So In terms of the clinical educator pilot, this has been incredibly important on the education side. You can see here that we appointed a group director for medical education and training, which reported to the chief academic officer. That group director for medical education and training had an administration team working with them and set up faculty in each of the constituent hospitals. The pilot was a resounding success. We moved in our southern region from having ad hoc arrangements in the hospital with volunteers leading out on education and training to a very formal system with appointed leaders for education and training with buyouts and administrative support, and being part of a faculty that met regularly to advance education and training in the region. It's been a huge success and is being rolled out nationally now. So that's part of the team of the Chief Academic Officer. In our region, this is the structure, the current structure, and there are versions of it in the different regions. And I'd have to say this is just one example, and this model is very much under discussion at the moment as we move from hospital groups to the regions. But the model that emerged was we have set up a governance and oversight group in the university. So the governance and oversight group is a group that is co-chaired by the president of the university and the regional chief executive. So they take turns in chairing this group, and on that group you have the directors of estates, the directors of finance, directors of HR, the important people on both sides to discuss matters related to joint appointments, education and training, research, governance of the dental hospital is another area, and so on. So that's really important to have a high-level group like that we can bring documents and memorandum of agreement to, and so that we can share our vision and share our goals, and where we can troubleshoot any differences between the two sides. So the Chief Academic Officer reports into that group, and then reporting to the Chief Academic Officer in orange, you've got the health service side, and in blue, you have the university side. The Chief Academic Officer is a member of the senior leadership teams of the university and the health service. And you have simulation lead, the Director of Education and Training, the College Vice Head for Research, the HSE Director of Research, the Clinical Research Facility Director, and the HSE Director of Simulation, reporting in to the Chief Academic Officer, who coordinates, I have to say, with a very light touch among all of those. And what's really nice is that the heads, the deans of the different schools within the college also report in. So it bridges among the schools, which are multidisciplinary: medicine, dentistry, nursing, therapies, pharmacy, and public health, and midwifery, all coming into a single point of contact. So very efficient. So we set up, to get there, we set up a research governance project, an integrated research governance project between UCC and the HSE Southwest. I thought it would take us 6 months to deliver this. It's taken 3 years. And I think an important learning from developing that research governance infrastructure is you have to go at the pace of the slower side, the less initiated side. You can't rush it. You have to bring people with you. You have to ensure that there's trust across both sides, and I would say trust is a huge factor. Our project goals were as follows. We wanted to develop a memorandum of agreement between the HSE Southwest region and UCC for integrated patient-focused research. Much of our work was informed by the work of University of Galway and CELTA, because they had done this previously. We also wanted to establish an operational structure, a shared research office that would allow our research administrators from the university side sit alongside research administrators from the HSE side, so that they would develop trust and a shared understanding of vision among them. We wanted ultimately to improve research, its management governance, and provide better healthcare outcomes for our patients. So following the HSE national framework developed by Dr. Teres, we set up a steering group with membership, equal membership from both sides. Now, on the university side, we had our Vice President for Research and our Corporate Secretary, who has a background in nursing and midwifery. On the HSE side, we had the Director of Finance and the Director of Quality and Patient Safety and the Director of HR. None of them had huge experience of research, so there had to be a lot of trust. But that steering group was established, and we established 6 working groups with 85 members from both organisations. And we were supported, importantly, by the UCC Academy for Project Management. We identified 41 roadblocks to clinical research, and we divided them. You can see most of them there in the green were on the operational side. But we developed an approach to addressing the roadblocks with buy-in from both sides and final approval by the project group and the steering group. The project outcomes were that we have our Academic Health Sciences Memorandum of Agreement between the region and UCC for integrated patient-focused research. It covers tripartite agreements, bipartite agreements, staff secondments, IP, all of those areas. So there were huge things, though, to address. And I'm delighted to say we had a place to bring it to. We brought it to our Governance and Oversight Group, which is co-chaired by the President and the Regional Executive Officer. So that system is working well. It's agreed by both sides. It's still out for a legal review, but it will be signed off in March. We have a shared patient-focused research office, an actual physical office with buy-in from both sides. We've appointed a director of research for the region, generously funded through Anna Terra's office, and we have research managers appointed. We previously had no research manager in CUH, we had no research manager in the region. Now we have research managers in both, and they have been transformative. And as I said, we have our top-level governance and oversight group, which deals with clinical research, education, joint appointments, dental hospital, and estate management, because we share estate, share premises in many instances. Remains to be seen if it will improve research, its management governance, and provide better healthcare outcomes for patients, but I think it will. So finally, I just want to say that the Chief Academic Officer role has been an essential bridging role, cultivating collaboration within the AHSS. And you can see how having that central point of contact brings together the HSE and the university. It develops communication, collaboration, and trust, and it can bring the research centres and integrated patient-focused research into very sharp focus within the health system. So it really paves the way for translational research. So thank you very much for your time, and delighted to take any questions.